our first speaker, Dr. Anagha, a very prolific surgeon from Bombay. Of course, all of us know her because she's at a national level today, managing everything and the practice, and to be a skillful surgeon is also something that really asks for too much. And we have Dr. Anagha speaking to us. Anagha, it's all yours.
Thank you. Thank you so much, sir, for giving me this opportunity to speak in your IC. And regards to Dr. Dua, sir, and to all our star speakers. So a very good morning to all of you. And today I'd be presenting a few cases which I thought were interesting. So I'd move on to my first case. So this is a routine cataract surgery. It's a posterior subcapsular cataract, so a routine surgery. And I just take you through the steps. So phacoemulsification, a routine irrigation and aspiration. And now we are moving on to the IOL implantation. Now watch carefully. So this is a single piece hydrophobic acrylic lens. So I'm loading it onto the cartridge with some visco in it and then taking care to see that both the haptics are in place. And I'm now injecting the IOL into the capsular bag. And now watch carefully what happens. The trailing haptic has got now stuck into the injector. So I'm trying to dislodge it from both the sides, but it's like, it's not just the tip of the haptic, it's the entire, from the optic-haptic junction to the entire haptic. So I would stop here to ask our panelists also, what would you do at this point of time? So I'm trying to open it, but now the optic has completely opened up. And it's not that it was just in the cartridge, otherwise I could have just retracted it. The entire optic has opened up and now this is the situation. So unfortunately, at this point of time, as I was trying to maneuver, there is a slight decimates detachment also, so I had no option but to extend the incision and then completely remove the IOL along with the stuck cartridge, and then we put in another intraocular lens. So the next time I thought maybe it's the haptic which had got stuck into that blue silicone sleeve. So now this is the next case that I'm doing. So now in all these cases, I think it's so important not to be in a hurry. Really see to it that both the haptics are, see, sometimes it comes back because of the memory. So I'm trying to push it 2-3 times, and until you're sure that it is very well, and very closely kept towards the optic. And then as you push it also, just see to it that it's not, the trailing haptic is not stuck in the blue sleeve. And then now each time I put in a hydrophobic single piece acrylic lens, I'm just, very careful to observe whether the haptic is coming out right or not. So this was another case. It's a preoperative picture of a phacomorphic glaucoma. So this was a 65-year-old gentleman who came to us with a vision of perception projection of light and an IOP of 50, which has been there since the last almost 3 weeks. And when we did an OCT of this patient, you can see that there is absolutely no anterior chamber at all. It's totally obliterated. It was an intumescent cataract, and the pressures were very high, corneal edema. So the challenges were a small pupil with posterior synechiae and very high IOP. In spite of mannitol, the IOP was still high. So we did a port, and that helped to reduce the IOP. And then it was also important to form the anterior chamber. So we pushed in viscoelastic, formed the anterior chamber, also released the posterior synechiae, but pupil remained the same. So now we had to stain the anterior capsule also, plus put in a pupillary expanding device, because remember it was an intumescent cataract. And there was a lot of pigment dispersion also on the corneal endothelium also, as you can see. So we're putting in retractors, but at this point of time, I found that the pressure was rising again. So one take-home message, what mistake I did was, we had removed the port, thinking that now that the IOP was normal, it would stay low, but the pressure shot up again. So this passive vitreous decompression, you can see the drop at the tip of that port. So that passive decompression helped to keep the IOP low. People also advocate going and doing a small amount of vitrectomy. Also, we didn't need to do that as the IOP remained low. Now, the second challenge was to do a good capsulorhexis. Fortunately, it didn't run out because of the good use of high molecular weight viscoelastics. And because it was not a very hard cataract, it was fairly easy to do the phacoemulsification and the cortex aspiration. But as I was putting in the lens, I found that the entire bag was a little wobbly. So I didn't want to take a chance, so I thought it's safer to put in also a CTR. So now in goes a CTR also for better capsular bag stability. And it's always important to stabilize the CTR with the second instrument so that the tip, the edge, the last tip also goes into the capsular bag. So now it's time to remove the iris hooks, and then I'll be putting in a little bit of diluted tricot to check whether there's any vitreous, and then that ends the case. So this was the second day post-op, 14 days post-op. In fact, the IOP rose up again. We also did a surgical iridectomy, but he had to be subjected to a valve procedure later. Third case is a patient who had been operated for a phakic-IOL for a very high myopia, almost 18 diopters, in 2014, and she came to me almost 6-7 years later with a nuclear cataract. Now in these patients, because it's an optically clear medium, an optical biometry gives us a fairly good IOL power result. Now this patient wanted flax. Now in patients with prior phakic IOL, when you're doing flax, we need to make certain changes in the settings. So I've increased the pulse energy also of the capsulotomy. The important point to note is the OCT considers the phakic IOL as the anterior lens capsule. So you need to manually shift those 3 dots there down. As you can see, otherwise it would have fired onto the phakic IOL itself. So you need to manually make those changes, and only then you would get a proper capsulotomy. Also, the pupillary edge is not very clearly delineated, so that also needs to be manually properly made. And once that is done, the capsulotomy and the nuclear fragmentation is done. Now, one more take-home message is this was an IPCL, which is slightly thicker and more rigid compared to the ICL. So if it was an ICL, probably I would have removed it before and then gone ahead and done cataract surgery. But here I thought maybe I would have to extend the incision. And if I try to pull it out through a 2.8 millimeter incision, it could have damaged the incision or the wound. So what I did was I was sitting temporally, I rotated it vertically, and now I am doing the phacoemulsification from underneath the IPCL. But note what happens as I'm doing the phaco, there is a radial tear in the anterior capsulotomy. So which means that doing a flax in these cases does not necessarily mean that you get a complete capsulotomy. It's a postage stamp perforation, but you need to be extremely careful. And in these cases, a very high myopia, 1 diopter lens with a radial anterior tear in the capsule, you need to be really very careful to see that there is no sudden shallowing of the anterior chamber. At the end of the day, patient did well and vision was 6/6. So this paper mentions how the laser beam that is deflected by the optic of the phakic IOL and the gas between the anterior capsule and phakic IOL actually induces radial forces, and this is a known fact. So we need to be extremely careful in these cases. This was the patient post-op. So I would like to end with one of these cases. This was a patient, a one-eyed patient, one eye lost due to a traumatic RD, and the other eye was a very high myope, 18 cut RK done, and then LASIK again done few years later. So you can see multiple cuts of RKs plus the metallic deposits in the interface. This is the OCT picture. This was the topography, a fairly good myopic ablation in the center, but a lot of keratometric variability on the EKR report. The dilemma was that whether to take in the post-RK IOL formula or to use the post-LASIK formula. So you can see post-RK, it is showing a 21 diopters on the Barrett 2K, whereas the post-LASIK, the Barrett 2K is showing 23 and the Higgs L is showing 27. So even on the ASCRS online calculator, on the post-LASIK, we did two readings. It was showing around 24 with a maximum of 25, 26. But as a post-RK, it was showing 20 with a maximum of 21. So we went ahead with a 25 diopter lens. And again, this patient wanted a flax procedure. So because of the few metallic deposits in the cornea, in the interface, sometimes that could cause a problem in the femto laser. But fortunately, the patient did well. So is my time up? Yeah, so this is just ending the case. So this was a free-floating capsulotomy and the phacoemulsification. In RK, you need to be very careful to have a slightly posterior limbal or a scleral incision so that the cuts don't open up. And this was a one-eyed patient. We put in a single-piece hydrophilic, and thankfully, the patient was good post-op. So I'd like to end here. So this was just a post-RK case. Yeah, thank you so much for your kind attention. Thank you.
Dr. Anagha, for a variety of cases, different situations in post-refractive situations where you have to make those changes. With regards to that, phakic lens, and when you do, I mean, your concern was that maybe you'll require to enlarge the opening to take it out.
Yes, so take-home messages we don't need to enlarge.
Yeah.
So finally, I could bring it out through a 2.8 millimeter incision. So I'd like you all to take home that message so that you don't need to make the same, go through it again. So I could easily remove it with a hand-on-hand technique through a 2.8. So even with the rigid IPCL.
Yeah, because contrary to what we do today, for every cataract we are looking at 2.2 or 2.4. But there was a time when all of us did phaco through 2.8. And 2.88 is also a good incision to do, provided you just remember the amount of extra astigmatism that you cause, which is not really much. So in these cases, if you have to switch from 2.4 to 2.8 doesn't really matter. But you only have to remember that your settings need to be slightly tuned up for 2.8, because when you are at 2.8, you may have to tone down on your vacuum and aspiration flow rate. Yeah. Thank you so much, Anagha.
Thank you so much,
please.
sir.
I just wanted to make a comment on your first case. When you're dealing with lenses that are not preloaded, when you put the lens in the cartridge and you clip it and you put the plunger in, it's always good to check the movement of the lens, because sometimes the haptic gets caught in the cartridge and you come out with a broken haptic with only one haptic at the other end.
Right.
And if the plunger is going ahead of the back haptic, you know you've got it wrong. And it should always, so we do that check, and because you do so many, you think you take it for granted, and it should move into the nozzle freely.
In fact, I now push it and then wait as the plunger retracts. You see whether there is any attachment to it or not. So that's the take-home message. That check that under the microscope and only then go ahead and implant.
But could you have tried to just pull the plunger out by holding it?
I tried it, sir.
It didn't come.
It didn't, because as I was doing that, I created a very small DMD also.
Okay.
So I thought it's better just to open it. I would just like to know what different, how differently anybody of you would have managed that case.
I mean, once it's stuck, it's stuck. So you have to take it out.
Was there a way to remove it without extending the incision?
I mean, the only one out, like I said, I suggested you would have tried to pull the plunger holding it.
I did that, sir.
And if it didn't come out,
didn't.
then you have to remove it. Yeah.
Ma'am, once I've tried to cut with the sharp keratome, just to cut the bevel of the
But
injector.
it was already
all the way.
inside.
Yeah, and
It
then
was
that
not
kind of opens up, maybe then the plunger may have come back.
This
it's
was
worked
already
in one
inside the
case.
wound.
True. It was a tough one to get out.
Anyway, thank you so much, sir. Thank you.
Thank you, Anagha.